So, for those would be giving their exams, if the examiner asks this question to you, be assured that you have passed the exam and is thinking about giving you a medal. Okay. Now, a lot has been spoken about cellular therapies. Though the topic was CAR T, I'll be covering the whole gamut of cellular therapies which are there in lung cancer. Rather than giving you theoretical things, what I'll be showing you the curated results of ESMO, STAC, as AACR and ASCO conferences, which have shown the initial results of these therapies. Most of you would be well aware of this, and so I'm not going to utilize my precious time in explaining this. Let's jump up with the what is the architecture of a CAR T. Now this is the short chain fragment variant. This is the one which actually identifies your antigen. This is the linker. The trans domain is CD8 alpha and CD28, and if you see, this structure remains same across all generations of CAR T. What differs is the intracellular domain, so which are the activating domain. The CD3 is a part of the TCR signaling pathways. Now the first generation CAR is useless. It cannot lead to T cell mediated destructions. So the results which you saw in 2010-2012 with early development of first generation CAR actually did not give any kind of responses. All the CARs who have got up till now FDA approvals are actually the second generation CAR, which required additional co-stimulatory molecules like the CD28 or 411B to be introduced. Now the third, fourth and fifth, it is not like second got converted to third and third got converted to fourth and fourth got converted to fifth. The second generations have been modified to make the third, the second generation has been modified to make the fourth, and the second generation has been modified to make the fifth. What is the modification done? The modification is done in a way that the T cell receptor signaling pathways get activated easily and the kill can happen much better. And how that was done? For the third generation, an additional co-stimulatory molecule was given. If it was CD28 here, OX40 and 411BB was given. In the fourth generation, which is also known by TRUC actually is the fourth generation CAR, a cytokine inducer was given. So which led to T cell redirected for universal cytokine mediated killing, and that's how the TRUC mnemonic comes. In the fifth generation, the second generation was modified to express interleukin 2R beta chain, which actually leads to activation of the JAK-STAT pathway and the PIK3C pathway. So all three pathways which are involved in T cell mediated killings all get activated. Now up till now we have the results for the second generation and some results for the third generation. The fourth and fifth generation results are awaited. The way this is, it seems that the results for these generations would be better than the generations for which we have got approvals already. Now today I am not going to talk about leukemia, lymphoma CAR Ts, which you may have heard ample amount of times or at ad nauseum amount of time. Now what are the issues when you use CAR T in solid tumors? And we'll start from this diagram below. For the CAR T to release the come up to the solid tumor, you need to have good angiogenesis inside the tumor. So if the tumor has a lot amount of fibrosis or the collagen is very high, your CAR T is not going to reach the tumor. So solid tumors which have a lot amount of fibrosis are unlikely to benefit with only the CAR Ts which are focusing on the mutations. You need to add it with something, and I'll show you what is added for them to destroy the microenvironment so that it reaches. The first thing is that it reaches there. Second is antigen loss. We all know that the tumor has the capability to shed the antigen or mutate the antigen. That is the second important thing. So how can we overcome that? We can make it for 2 antigens, we can make it for 3 antigens, which improves the killing of the CAR T. The third is T cell exhaustion. There is so much antigen there that the T cell actually gets exhausted. And how to overcome this? The doses which you give in CAR T therapies in liquid tumors and in solid tumors are remarkably different. The kind of dosage which you need to give in solid tumors are 20 to 30x higher to overcome this. Now there is also inherent resistance. One of the mechanisms by which the CAR T kills is by interferon mediated pathways. So if the interferon signaling has been hampered, it won't get killed. And if your target is such that it is not specific for the solid tumor, but it is also present in other sites, then off-target activity can be very, understand that you are giving higher doses here. So the off-target activity can actually lead to a loss of therapeutic ratio. And sometimes the tumor microenvironment would have so much amount of MDSCs and Treg cells that even if they get activated, these would put rest to them, and that's why many of the solid CAR Ts you would see that the results are coming with addition of checkpoint inhibitors along with them. Now, what are the types of CAR T? There can be multiple types of CAR T. It can be alpha, beta, gamma, delta. It can be auto CAR, in which it is made from the patient's own blood. It can be allogenic, which can be made from other patient's blood. And this can be even for alpha, beta. So you can have 4 permutation combinations here. There can be types according to the generations. But what I want to show you is this, which in solid it would be more important, is the number of antigens which are expressed. Multi-targeted CARs, in which you actually try to infuse 2 different CAR Ts against 2 different antigens which are found in the same year. But there are 2 different CARs which are going here. You can have something which is called a bicistronic CAR, in which is a single CAR which has expressions of 2 different T cells CAR T together. You can have a tandem CAR in which the short chain fragment variable, which was actually identified, there will be two short chains to the single CAR which is doing bispecific or trispecific work. And sometimes what happens, the activations can be so high that you need to have a kill switch or a stop switch. Understand that unfortunately the CAR T goes inside the blood, it keeps proliferating only. Theoretically you can insert a leukemia inside. So you need to have a kill switch also. And because the number of cells which are given are so high, you sometimes then have to think about having a split and an inhibitory CAR which also is transfused, so that if it goes above a level, this starts taking control. Now what I am going to show you today is what are the results which are there. Up till now I wanted you to have this some amount of background knowledge, because what I am now going to show would get correlated with what we have talked up till now. Now there are multiple targets which in non-small cell lung cancer have been tried, and these were the trials which are going on a few years back, and phase 1 results of these have already come for MUC1, for EGFR, for ROR1, for mesothelial antigen, and for prostate cancer specific antigens also. Now we heard about small cell lung cancer by tarlatamab. We have actually have good data for DLL3 CAR T also. Now another thing you need to understand, that is the subtle but important differences between what is a CAR T and what is a TCR therapy. And understand that when you are going to make things very specific, for example, when you want to make an autologous CAR, the patient has to wait for 30 days. In a solid tumor, a patient who has exhausted all treatment options, who has progressed on multiple lines of therapy, if you are going to ask the patient to wait for another 30 days, the patient general condition is going to deteriorate. And that is exactly where allogenic or off-the-shelf CARs, in my humble opinion, would be a more approachable way of treating solid tumors. Now, the more specific you make, it is not scalable. What does scalable has to do with this? The more individualized it is for the patient, the costly it is going to be. You cannot do mass production. Everyone's blood has to be taken, for everyone it has to be made. The more non-specific or more allogenic it is, that is more scalable, so the cost will come down. Now let's look at what are the hot targets in lung cancer for which we already have some results. These are all the targets. I'm not going to read it for you. You can read it yourself, for which we have the results and I'll be showing. And these are some more targets which can, for TCR, which we have the results and bytes. And let's look at some of these glycoproteins. It's an oncofetal protein, GPLC3 specific with tumor growth factor beta CAR. This has been used in hepatocellular cancers. Now you all know that targeted therapies, they can be used with respect to the target wherever you found. These again, like targeted therapies, are not tumor specific. These are tumor agnostic. So they are specific for the mutations. What is interesting is this data which came in 2023, if you could see that the early response rates in post 2 to 3 lines of therapies in the patient was 4 out of 7, that is nearly 50% of the patients had some kind of response. This ASCO, this data was presented again in 2024, around 2 months back, and you have updated results of 22 patients in which you could see that the response rates are to the tune of 50%. Now what's interesting is the same protein is also expressed in around 3 to 5% of squamous cell carcinomas, and very similar results, and the expression levels are higher in HCC than in lung cancer. Let's look at DL33 BiTE for neuroendocrine tumors, and these results are tarlatamab well presented, so I won't spend time on this. You understand 85% of small cell lung cancers have this expression. The response is 40%. There is minimal CRS with the BiTE antibody, and you get median OS of around 14.3 months in third line and beyond setting, which was unheard of. Now the question is, for BiTE, you have to give multiple infusion. I have treated one patient with tarlatamab. You require to give multiple infusions to the patients. The idea is, can we make this infusion in one single go? In which what we do is we create an in vitro BiTE inside the patient's body so that it continuously keeps making the immunoglobulins, which is actually possible by something which is known as engineered B cell medicine, BCAM, which we can get engrafted in the patient without any preconditioning. It will continuously secrete the BiTE around 1000 molecules per second per cell which gets engrafted. So what actually this can done is, in one single infusion, it can take care. We don't need to give multiple infusions to the patient, and the CRS also will be less. Now what kind of results we are seeing with BiTEs in this situation? If you see that if you don't have a prior PDL1, the response rates are as high as 56%. If you had prior PDL1, you have 32 to 42% response rates along different shape, but be prepared, when you use this, you are going to get CRS in nearly 60% of the patients. Now understand that when you use cellular therapies, your side effects are like efficacy side effects. You don't get side effects, the patient is not going to benefit. So you want the side effects to happen, but you want them to happen in limited period of time. Now I told you that one of the issue is many of these tumors have fibrosis. So you may want to break the fibrosis also with you, and hence comes the concept of an armored car. So what is the armor which this car has along with it? It is actually this tumor growth factor beta ligand which is there along with this. So if you see this design, you could identify this is a third generation car which actually has another dual receptor along with it. Now this is actually to promote your infiltration in the tumor microenvironment. What has been seen in cell line data, you could see here that when you use an armored car, the cell count actually goes down and down. This study has been already started recruiting. The first patient has got recruited. Then update was given in ASCO this year that the patients are doing well. The long-term data would probably come in this ESMO or in AACR conference. ICAM1 in thyroid cancers. And this again was updated in this ASCO 2024 session, in the poster session, in which you could see some dramatic responses in which there was a good amount of tumor shrinkage, and interestingly in this phase 1 there was no DLT which was reached. The response rates in these were thyroid cancers. This was anaplastic thyroid cancers, and actually this poster was just 2 posters behind Nandini's poster this ASCO, in which the response rate was around 33% and DCR was 67%. Interestingly, ICAM1 is expressed in nearly 33% of non-small cell lung cancers, again given very good option that this can be used here. Now, if you can target something which is called as PRAM, this is an HLA dependent. So if you have an HLA dependent, you need to do an HLA matching before giving this CAR. And this HLA dependency can be seen in only around 20% of lung cancers. And you could see the confirmed response rates were around 47%. Now, cellular therapies will also come with vaccines like mRNA vaccines. Now, these are specific vaccines which have been made for the patients, in which the patient tissue needs to be taken up, You make the vaccine against the neoantigens, and how many neoantigens of the cancers are taken? At least 34 neoantigens are taken, and the vaccine is cleared. So, it's again a specialized vaccine per patient. So, actually, the manufacturer makes one lot per patient. So, again, this will be individualized, so it cannot get scaled up. Its cost is not going to come down anytime. The interesting thing is the data of it initially seems to be looking very good. This actually would come as a this has come in JCO and in Lancet recently, and these updated results will come in around 2 years, in which we'll come to know how good this result sustained. But the way the curves seem flattened, this seems to be something which would come on the horizon. Now, tumor infiltrating lymphocytes or gamma delta T cells therapy infusions. Now, this is an interesting article which came in Journal of Immunotherapy of Cancer, which actually said that in diseases like melanoma, in which you keep giving ipilimumab or combinations of multiple checkpoint inhibitor for a long period of time, as opposed to you give single infusion of TIL or 2 infusions of TIL, it is actually going to be more cost effective, because the patient does not have to come for so much long treatment, and the cost will also be better. Now, what if we use this TIL in non-small cell lung cancers? And these were patients which were post 4 lines of therapy at least. And what you could see here is that a good amount of response rates were seen. You could see that except there's 5 patients in this, everybody responded, and there were CRs also seen in these patients. And was this sustainable? You could see the data is still 3 years, that is pretty good, sustainable. So another options of this is for the gamma delta infiltrations or the TILs, in which you can do for these patients. Interestingly, it was seen that, as I told you, multiple patients had multiple lines of therapy. If you have received less lines of therapy priorly, this had a better response rate than those patients who had received more lines of therapies. Now, there are now trials which are going on to how to improve upon TIL by trying to add different types of interleukin regimens so that they get activated and they respond better. And these trials have actually lead to a stoppage of the clonal toxicity also, if it gets integrated with the CAR T itself. Now, the last few minutes I'll visit on the classic targets for dual targeting for these regimens. These were the results of I won't spend much time, of the first generation CARs, in which we actually landed up with great amount of side effects. CEA expression is not uncommon in non-small cell lung cancer. Now, understand that when the initial CARs were made for CEA, they lead to a lot amount of toxicity, and one of the reasons for toxicity was off tumor targeting. CEA is expressed in multiple organs in the body. So what it was done was, along with, this was the design of the CEA CAR, you added HLA-A, that is targets the clonal heterozygosity of the tumor. So now the off target can get activated only when it is on target, in which you have actually put a marker which is more specific for the cancer cells. Now the issue is, this blocker is expressed in 30 to 50% of the patients. What they did was, a very efficacious CAR was toned down, and its therapeutic ratio was increased. Now, how would this lead to an improvement in therapeutic ratios? What it was seen was, when you had this toning down of the CAR, the therapeutic efficacy remained the same, and the side effect profile came down. This is something which was required even in the PSMA CAR. Now, PSMA expression is there in the brain, it's in the lung, and obviously it's in the prostate. It's seen in some patients of pancreatic cancers also. Now, if you see, when the PSMA CAR initially came, there was dramatic PSA response rates of more than 98% which was seen. But what we landed up was with fatal toxicities. And why was this fatal toxicities? This is another situation where you give only PSMA CAR, it does better. When you give the PSMA CAR with a tumor growth factor beta, Along with that, which leads to more penetration in the tumor microenvironment, we have started seeing a lot more amount of neurotoxicity and even deaths with that. So this development for PSMA with a tumor growth factor beta has actually stopped. What has come with that is to make it more specific by addition of a CDCA9 molecule, which can actually switch off the mechanism of the CAR if it gets too much. We also have HER2 CARs which have got into development, which obviously would be used post-trastuzumab, and they also have started showing good results already. Now, you can also target for neoantigens. For neoantigens, you need to use TCR therapies, and this is an example of G12D pancreatic cancer neoantigen which has been done. And we know that KRAS is infiltrated in multiple types of tumors. This is an example of a anti-P53. So you can understand that the P53 is a important molecule, and not important, it's an important mutation, and it's there in nearly every cancer which we treat. And I remember Amol having a discussion with me that something needs to come for P53, then things would change. And I just wanted to show that we have development of a P53 card which has already started, and you could see that the results seems to be quite amazing in patients who have received multiple, and this is actually multiple lines of therapies which have started coming. We also have the KRAS G12V. G12C thankfully has not been formed. I think that the way G12C is going to go where sotorasib adagrasib way, but G12D, G12V, G13C are going the way of cellular therapies. For this also, the results are quite promising. So what I'm trying to tell you is that we are maybe on the horizon of seeing something which is very interestingly in development of cellular therapies. Solid tumors are not going to be far behind. The development will require some out-of-the-box thinking, like adding destruction of tumor microenvironment, addition of interleukin-2 or TRK kind of things. But definitely the way things are, the response rates in most of the things are between 30 to 50%, and they seem to be sustainable, at least in the TIL kind of a section where data is there till 2 to 3 years. Similarly, a gamma delta protocol and a CAR-T allogenic protocol will be starting at our center. And this has a non-small cell lung cancer of 88 patients which needs to be recruited. We believe that with the DCJ approval, this would start somewhere between November. And that's it. This is the team of SUNACT. I invite you, anyone wants to visit the center, come and see the center, wants to see some allogenic CAR-Ts how it are done, you are free to just catch hold of me and come down to Mumbai anytime. With that, thank you. Yeah? Yes. Correct.
There's a potential to develop the cellular therapy for gallbladder particular. So any reading recently about ELF3 protein?
So, Amol, you know that I don't really like gallbladder cancers. So, my reading remains restricted to head and neck, lung cancers and CNS. That's the reason why my knowledge in those directions are much higher. But the thing is, potentially any antigen, it has to have 4 criteria to make it. A, it should be largely restricted to the tumor. Second, it should be as possible to get identified on the cell surface. Third, it should not be shed by the tumor. It means it may shed as a resistance mechanism, not in the blood. If it sheds in the blood, the CAR won't reach the tumor. And the last is, the important thing is that there should be activating pathways because of those mutations. These are the properties from the tumor side. The properties to make this is, we can make the vectors in 2 ways, the genetic engineering. Either it would be a viral based or it can be electroporation based. These are the only 2 methods. The viral base, the whole depends upon how much an adenovirus or the lentivirus can carry, how much segment of information can go. If that segment of information is within the load to be carried, it can get created. Electroporation can also help, but that would require slow dissemination. So if that is possible, I will be happy to see with which labs. And this is, the problem is, most of this data, like I saw, you won't get in PubMed, it does not come in mainstream. These are many times I had to curate this presentation. I had to go to a lot of posters in which were published in SciTech, ASCO, or an ESMO. Much few of these data don't get published in those journals in which we read. Gets many times get published in engineering journals or biotechnology journals, unfortunately. Thank you.